Hi, everyone. Welcome to the first episode of the Public Health Podcast. We are Kevin and Zio from the Harker Public Health Club, and we were so happy to be joined today by Dr. Yan Xing. Dr. Xing is currently a frontline doctor working as a primary care provider in San Diego. She attended Case Western Reserve University and is now a junior resident at UCSD with an MS and MD degrees. In this episode, Dr. Xing passionately shares the experiences she has encountered during her work in COVID times. She also discusses the three types of vaccines, trends for getting back to normal, herd immunity, COVID 19 variants, and concludes with advice for young people seeking to help out during this time. The following is the passionate discussion that she had with us.
Hi, my name is Anne, or you can call me Dr. Singh. I'm currently a second year internal medicine resident at UCSD Internal Medicine Program. I'm here to share my experiences and answer questions that about COVID pandemic or any questions are COVID related. So as part of the medicine physician duties is to take care of patients who are hospitalized, as well as patients that are outpatient through the clinics. So I was able to take care of a variety of patients in different settings during the past year and a half. I took care of ICU patients, so patients who required intensive care unit, who had to be taken care of through the intensive care unit at the peak of the COVID pandemic. So in July last year and January this year, I was also able to take care of some patients who were hospitalized at UCSD Hillcrest and La Jolla. Also, I had the privilege to take care of some patients through my outpatient clinic in different settings. So I'm here to share my experiences and answer any questions that people have.
Yeah, absolutely. You've had many years of experience in the medical field, of course. So could you tell us a little bit about how COVID affected your work and some of the challenges during the pandemic and how your day to day kind of changed before and after the pandemic?
That's a really good question. So I think the COVID pandemic hit the San Diego area around March last year, so almost exactly the same time, or a little earlier, a year ago. We were in a way unprepared. I think there was a lag between the Eastern time. At that time, New York was already hit very hard, but we were not very prepared in terms of our PPE supplies, and then just in terms of rotations wise, like we will need more people to cover the inpatient unit. So I think at the beginning was definitely a little bit more unprepared. We didn't have adequate access to the PPEs, and there was some stigma at that time, also debate of whether wearing a mask will prevent COVID. Is that really necessary? So I was working at the VA at that time, at the infectious disease consult unit. So we got lots of questions from other team members, and the CDC guidelines were changing a lot as well. So we were given one mask per week. So we had to keep the same mask for the whole week at the beginning of the pandemic. And if your mask was damaged in any way, so there was one time that the side of the mask fell off, we had to staple it back because there's no more mask for us. Which now it sounds kind of ironic because we all know that we need to wear a mask and that's the best way to prevent the spread of the pandemic. I guess at the beginning there was a lot of unknowns about what to do. So that was the situation, and then we had a lot of struggles getting access to PPE, even while we were working in the ICU at that time. So I had a patient that needed, I highly suspect that he will have COVID, and I was requesting to have gowns and a surgical mask, and N95 especially. I had to go through a whole protocol in order to get access to N95, because they wouldn't be able to give those masks freely to everyone. So I had to put in a request form and justify why I think this patient has COVID and has to be reviewed. And then all the masks will be stocked with the charge nurse. So I had to go through the whole nursing staff in order to get the mask. So there was a delay in the patient care at the beginning for sure. And I think things in terms of PPE supplies and just our understanding of COVID got significantly better around May. So around May time, that's when CDC guideline changed, saying that it will be important to wear a mask and social distance. They also studied that wearing a mask in the inpatient setting, taking care of patients, will prevent the spread of COVID in the hospital setting. So that's when the PPE supplies became much better, and I was able to get good access. And in terms of the workload, I think that the July, when I worked in the ICU, and that was the first of the peak of COVID, was definitely pretty tough. Because at that time, there's still mixed voice about what COVID is about, what COVID kills people. I think, unfortunately, leadership of the country at that time didn't help. So there was a lot of rumor in the community that COVID is not it wouldn't be the cause of death or cause of severe illness. So I had patients that were hospitalized and for weeks and weeks and were really sick. And then I had to call their family, communicating that their lungs were severely damaged because of COVID. And I still got the questions like, "Oh, I didn't know that COVID would be this bad. I thought COVID wouldn't kill anyone." Because of the rumors and the popular media at that time. So there were a lot of challenges. We have lots of patients that are international, so their family is still back in Mexico, but the border was closed. So the only way to communicate to the patients that were ventilated, of course, once they're ventilated, they won't be able to communicate to us directly. So we'll have to call their family member who live in Mexico, would be through phone calls or iPad. And a lot of the patients' families were not very technologically savvy, so they wouldn't know how iPad works. So there were a lot of times that we have to talk them over the phone and communicating that the patients are not doing very well and this is basically the end of their life. So they have to make really hard decisions over the phone, like whether to withdraw care or continue aggressive care, knowing that they might be diminishing return at this point. And then we had lots of heartbreaking conversations over the phone. I think not seeing the family member and then put that stress on the family members internationally, because the border was closed. They would require a different type of visa that wouldn't be granted in time to make the decisions. That was really hard from a provider's perspective, also from a family's perspective. We also did some what we call compassionate extubation, meaning the patient was near the end of their life, and will have to be extubated at that point through iPad. And then to me, that was the toughest, because in order to understand the gravity of the situation, I think a lot of times having family invited to visit the patient is the best way to see what I'm talking about. Because a lot of times I'm talking about, the patient is very sick on 4 different pressors. We have to make sure the patient is paralyzed. It doesn't really make a lot of sense without the context, without seeing what the patient is actually going through. So those aspects are really difficult. And I also took care of patients in December and until February in the inpatient setting this year. And we all know that's the peak of the pandemic. I think it's difficult for patients who are near the time of intubation to make that decision. Do they want to get intubated knowing that we almost had no success getting them off the ventilator, or they're going to suffer without the ventilation just purely on oxygen? Their numbers are really low, they're suffocating, and we know that's not the best route. So those are really difficult decisions and difficult conversations to have with patients. And I think just calling family and letting them know that on a daily basis, when they ask us like, "Oh, what's the success rate?" and I have to be very honest with them that we didn't have anyone successfully extubated for almost a whole month. That was a really tough statistics to give to the family member.
Yeah, thank you so much for sharing those stories and experiences. It's really moving. And I think one of the things that could provide some hope is that we are starting to distribute vaccines. I think the latest number is that nearly 20% of Americans are fully vaccinated and 35% have already gotten the first shot. So I guess the question that people are wondering is how much are things improving, and how long do you think it would be before we can perhaps get to normal or reach herd immunity?
Yes, so I think in terms of the trend, if we look at the January-February statistics in terms of ICU capacity as well as the number of patients ventilated, at that time it was over 200 at UCSD alone. I'm talking about other hospital systems as well. And then I just from a insider point of view, we didn't have ICU bed available for a long time, and that was the peak of the pandemic. So things, since the vaccines were getting provided to the medical staff first, and then to the patients at the SNF, and then gradually to patients with, who are elderly with medical comorbidities, we see the numbers coming down. So I actually just checked this morning. I think we only have around 10 to 20 patients that are hospitalized at UCSD, and then we're talking about single digits for patients who are on ventilator, and that's a drastic decrease from over 200 at the peak of the pandemic. So things are definitely moving in the right direction. I think the term herd immunity, of course, is all hypothetical, but just in general, we're looking at least 75% of the general population being vaccinated. To think that we have some sort of protection from each other. So I think until we reach that number, things wouldn't return to quote unquote normal. Of course, that's a gradual situation that California is looking at completely eliminating the color system in 2 months. And right now we have just been downgraded from purple color to orange color, meaning that we have a lot more capacities available from indoor dining, entertainment is opening. Things are gradually back to where it was. Of course, with social distancing, with masking, and then until we reach that number, the 75%, and then until things remain stable as what it is, I can't see things completely back to being normal per se pre-COVID. But I think we have the flexibilities now, enjoying somewhat what we were enjoying before. The restaurant scene, and some of the entertainment, and some schools are opening back to in-person learning as well. So I think things are returning back to where it was gradually.
I think we can all definitely agree it's really hard to get access to the vaccine at this point. And I was just wondering if, from a healthcare provider's perspective, you've noticed that there's any sort of socioeconomic barrier to getting the vaccine and what that might look like.
Yeah, so I take care of patients from a variety of backgrounds, and I've definitely noticed that for patients who don't have, a good computer system, who are not very technologically savvy, are the ones that are are facing the most challenges, because all these vaccine slots have to be made online, or if you jump on the phone, from what I heard, it can take hours. And for working class, nobody has the freedom to stay on the phone for hours just to be booked for a vaccine. And of course, for patients who have their PCP, meaning that they have established care from any of the healthcare system, for example, UCSD, and UCSD would be proactive to reach out to those patients and offer the vaccine slots. So that would be a lot easier for them to book through any of the UCSD sites, in that sense. But there are lots of patients who unfortunately don't have their PCPs for whatever reason. Lots of people have their insurance change all the time. They don't have time to establish care with a PCP. And those are the ones I think are getting discriminated the most, because there are a lot more loopholes they have to jump in order to get vaccinated. And for patients who have questions about the vaccines, if you don't have a primary care doctor, or if their primary care doctor is very busy, or they don't have a single person they can talk to, it becomes much harder. So I have patients that have questions about COVID vaccines, and then for me as a provider, just offering a personal story that I have been vaccinated, and these are the side effects that I personally experience, and this is the experience I have had. And seeing that face and just hearing that voice from a personal point of view helps a lot of them to make the decision to go ahead and vaccinate it, because this is the first mRNA vaccinations that human being have ever encountered. And I understand that why people, patients and everybody has uncertainties about these vaccines, because it's something that we've never had before. I think it's just hopeful to hear from anyone they trust, to share that perspective, and then without having the PCP is, I think, the most challenging part from a social economic point of view.
Yeah, that's really interesting. So I think you touched on this part, but I was also wondering about because we know that the vaccine public distrust is a really big challenge in the vaccine. So why do you think there's so much hesitancy among the people to take the vaccine? And what do you think are the recommendations for public health experts to best ways to approach the public to ensure the public trust in vaccines, so we can get as many people vaccinated as possible?
Yeah, that's a really good question. I think in general, this traces back to this this anti-vaccination paradigm that happened many years ago. There was a paper that came out of Lancet saying that there was a study saying that injecting MMR vaccine in children can cause autism. Therefore, a lot of the Hollywood celebrities stopped vaccinating their kids, and that's led to the outbreak of measles. So that was maybe 20 to 30 years ago when this happened. And that started this whole, trend of people starting not to trust the vaccine, and vaccines are getting, in a way, there's politics of vaccine. So people will see this is science versus anti-science, or religion, if you call that, or they call it, this is big pharma versus, anti-big pharma. So it completely, once there's a political element involved in anything, it becomes more difficult because we cannot get the neutral perspective out. I think that just in general, every year we see only a fraction of the population getting vaccinated with flu vaccine, which is recommended for everyone. And then every year, a large portion of the elderly population unfortunately die of influenza. And I think it got exacerbated over the past year during the COVID pandemic. With the leadership saying that COVID was not real, there was a lot of distrust in COVID in general. There was a lot of discrepant voice about what COVID was about. And I think none of this would help with the COVID vaccine. Now it's a new form of vaccine that's come out because there was a lot of confusion about COVID itself, as well as this trend that people are looking at. They have a lot of doubts about vaccine in general. I think a combination of these elements all have led to questions about COVID vaccine. And then what I have found out interestingly is that if you talk to someone who don't believe in vaccine at all, just talk about your fear and your concerns, and then you relay yourself, yes, I'm vaccinated, my families are getting vaccinated. So it's not just something that I will offer to my patient. It's something that I have done, and then I experience side effects, and this is what I have done. And patients, if they can relate to you, it's not something that, it's not about power relationship. It's not about a doctor telling a patient, or in a way forcing a patient to do something. As someone, as a friend, offering my personal experience. And I found out that a lot of times, if they have questions and concerns, I talk through about them through a personal experience, and then they're more acceptable. And then lots of patients are actually, I got the vaccine in the end. And I really wish everybody could have this opportunity to talk to someone. Not necessarily a doctor, although I think it helps to hear from a doctor, just anyone about their personal experience going through this pandemic and going through the vaccination process.
Yeah, definitely. I think that personal connection is really important when it comes to talking about the pandemic and talking through different perspectives. And I just wanted to ask, in relation to the vaccine specifically, can you explain a little bit about what doctors mean by vaccine efficacy, and what are some of the differences between the three vaccines at the moment?
Yeah, so at the moment, we have Pfizer, Moderna, and Johnson & Johnson. I don't know Johnson & Johnson the best because most of the vaccines that are getting offered through my clinic site are Pfizer and Moderna. And they are mRNA-based vaccines. With those vaccines, as I said, this is the first time that human beings are seeing mRNA vaccines. They're getting injected, and then they create the antibodies that will be fighting the COVID virus. And then Pfizer and Moderna are 2-shot vaccine, and Johnson & Johnson is 1-shot vaccine. And then the first Pfizer vaccine requires 2 shots, or ideally 21 days apart, and Moderna will be 4 weeks apart. So when we're looking at the efficacy, the original papers when they study those vaccines are based on clinical trials. So they have 3 stages of clinical trials, and we're looking at clinical trials from human studies. So volunteers that will go ahead and get placebo, meaning saline, or nothing in it, versus Pfizer or Moderna. So they're looking at over time how many people would contract COVID, provided that they will be in similar settings, they will be in the same community, they will be having similar comorbidity profiles, for example, heart disease, hypertension, age. They will have similar things, and then match their characteristics, and then look at their outcomes. So how many people get COVID by the end of 6 weeks or 8 weeks, having them got the vaccine or the placebo, meaning nothing in it. So it will be a double-blinded study, meaning that neither the patient who received vaccine or the researcher knows that what they are getting. So by designing this, what we call randomized control trials, meaning that it's completely randomized. You could be in the control group or the placebo group. And then I don't know where you're getting. Nobody knows where you're getting. And then we're looking at your outcome. How many of them will be getting COVID, and how many of them will be getting COVID so bad that they will require hospitalizations. And then that's what they call the efficacy number. And at the end, they have these outcome numbers. Okay, so say 3 people in the vaccine group have got COVID by the end of it, and then say like 120 people, provided that they have similar characteristics, similar exposure, have got COVID. And in a way, then you plug in the calculator, and that's what you got was the efficacy number. So interestingly, now Pfizer have extended the eligibility to children above the age of 16. So they specifically studied children above the age of 16, and their result is that for patients, younger patients that got vaccinated with Pfizer, nobody got COVID, and then there's a few of them got COVID without the vaccine. Therefore, their conclusion is that Pfizer will be 100% efficacious to the younger population. Of course, nothing is 100%. We know that. Even with the best vaccine, wouldn't be 100%. But that's just based on the studies. That's the number we get. Of course, there are limitations of all studies, and clinical trials for sure have a lot of limitations. For example, they're looking at some. I got that. I was asked about this question about Moderna. They said that Moderna was like 94% efficacious to the Asian population specifically, and Pfizer might have been like in the 70s. Is Pfizer more inferior vaccination to the Asian population? Based on the study, yes, but if you look more closely about the number, you will find out that Pfizer didn't recruit that many Asian patients to start with. So if our sample size is smaller, the number will have less power because we didn't recruit as many people to have the result to have a generalizable is what we use that can be generalized to the population. So the smaller the sample we have, the less power the study is. So that number doesn't really mean much if we don't have a lot of the patients that were recruited. So those are the limitations because it was based on a smaller population, and then we didn't really include a very diverse set of populations, and the patients, the ones that recruited with the comorbidities may not be the ones that patient has. So it is very individualized, but just from a patient population, like a large scale perspective, vaccine has shown to provide benefit, has shown to be quite efficacious against COVID. And then just looking at the timeline of patients that are ventilated and hospitalized, and the timeline of when the first vaccine was getting administered and the number of vaccines over time, we definitely see a correlation. Nowadays, the COVID surge is over, things are opening. We don't have as many patients sick with COVID, and certainly not as many patients sick with COVID getting hospitalized. So overall, that's a positive trend. And I think from that, we can also draw the conclusion that the vaccine has provided benefit.
Yeah, for sure. And I think that's a really important point in terms of like, instead of comparing the vaccines, focusing on how we have 3 really good effective vaccines and getting everyone vaccinated as soon as possible in terms of like taking the vaccine at the earliest availability.
Yes.
And also another question I think related to this topic is I think a lot of people are hearing about the different variants of the COVID-19 virus. So could you just help explain like what are the differences between the variants and how much should we be worried about new variants in terms of like, for example, not being susceptible to the vaccines that we have?
That's a really good question. So as we know that viruses mutate, that's why every year we have to register the flu vaccine. And then the flu vaccine, this is kind of off topic, is based on the prediction of this year what a mutant would like. So just by the natural history that the virus has mutated, and then we know from what we know, there's the British mutant that is a little bit more prevalent in the United States now. There's a Brazilian mutant, and there is the South African mutant. So there are slightly different variants of the original SARS-CoV-2 in terms of genetic coding of it. I can't give you like exactly what the genetic coding the differences are, but in general, the purpose of mutation or evolution in general is so that it can spread a little bit more, it can cause more death from a virus point of view. If we want to survive from a virus point of view, we have to spread to more people. I have to be a little more dangerous, right? So that's the challenge for this new mutant is that it has a higher what we call infectivity, meaning that we're looking at this particular coefficient that predicts if someone has virus, one person, how many people it can be spreading out in a general setting, without masking or so on and so forth. And that's the challenge because we know that it has come across the ocean and now it's in the United States. And then I just recently listened to the broadcast that it constitutes almost half of the newly diagnosed COVID-19 cases, meaning that it is showing that it is spreading out. So I know that Pfizer has put out a statement that it is protective of the COVID of the British mutant. Don't know about the efficacy against Brazilian or the South African, which are not as prevalent. But we can anticipate that as time goes on, these mutants will, not only become more prevalent but also continue to mutate. That's going to happen. And then this is an ongoing study of whether this vaccine will be protective of further mutant. We don't know about that. So our hope is that I think that will happen is to have booster shots. So now we have 2 shots of vaccine, which are protective of the existing COVID, and hopefully the British mutant, which there's still data that are coming out, so we don't know for sure. But the data that have come out is saying that it is protective. And then hopefully with the booster vaccine, meaning that once you are already fully vaccinated, you administer booster vaccine, it will give you additional protection. And hopefully our research is going to come up with a booster vaccine later this year so that we can continue getting the protection. And I think the challenge with the booster vaccine is that you have to be fully vaccinated first in order to get a booster. You cannot just show up, okay, I'm getting the 3rd booster shot today. That's not going to work. So that's why we're stressing the importance of everybody getting vaccinated today. And then there's going to be research, hopefully with the booster shot coming out soon. And then we are having more studies coming out. And then that goes back to why it is so important for everybody to get vaccinated today.
Yeah, definitely. And I guess our final question for today would be, so there's a lot of young people who see everything that's happening and really want to find ways to help out. And so we're just wondering if you wanted to talk about any ways that we could get involved and help out.
Thank you so much. First of all, I was very privileged that I received so much support from lots of different community groups during the COVID pandemic. At the beginning of the COVID pandemic, when we didn't have reliable access to PPE through our institutions, I was able to receive N95 through the donations here. I was able to receive lots of supplies, and that really helped me to go through that really tough time that we really didn't know enough about COVID. There wasn't enough supplies. And then I received free lunches from the local schools here, and that was really nice. And then each lunchbox, there was a photo attached by the front of some drawings, and they're like, "Oh, thank you so much for your hard work." And it just brightens your day, when you're going through a tough day, not necessarily COVID, but just in general, a stressful day taking care of patients. It's so refreshing to know that, community members are very appreciated. And I think just looking back from if I were a high school student, what could I have done, to help to support the COVID? I think one thing is that to just tell the young people around you that about the COVID vaccine. I think a lot of the if you were looking at the statistics, the patients that have the most resistance to the COVID vaccine are actually the younger generation. Interestingly, a lot of the elderly, either 65 and above, have already been fully vaccinated. Through my clinic time, I've only maybe met 1% or 2 people that were not vaccinated at above the age of 65. And the vast majority of the patients that have doubts or concerns about COVID vaccines are actually younger. And also they don't feel as much threatened by COVID as the elderly patients, because the elderly know that if they get COVID, it can be very deadly. And I think it's just helpful to stress about this to your friends and to your family members and anyone that you interact with about the importance of getting COVID vaccine, and also to act as a role model to the young people. Still continue practicing social distancing, continue wearing masks. I think it can be so easy to relax on it as someone who is young, because COVID is basically dying out at this point, quote unquote. And then anyone in the age of in the 20s who would get COVID probably wouldn't die from COVID. It would be an inconvenience, but that's what has caused the pandemic at the beginning. So the younger people who got COVID, that unfortunately will be spreading out to the community, will spread to your mom, to your grandparents. And that was the saddest when I saw from an ICU point of view, is that a lot of the elderly patients who died of COVID got their COVID from their kids. And then it's just hard, when the kids will be blaming on their behaviors, and that would have been too late. I think as high school students or anyone who's young, continue practicing and then advocating that it is still important to practicing social distancing, wearing masks. That will be critical to head in the right direction to potentially end the pandemic.
Great. Okay, so thank you so much, Dr. Singh. We really appreciate you coming today, and it was really interesting getting to learn about the pandemic from the perspective of a frontline doctor. So thank you so much for stopping by.
Thank you. And then I just want to say that anyone who's interested in becoming a physician or interested in medicine in general, I'll be happy to mentor. I know that this year was a definitely tough year, but I think it's such a rewarding career. I have no regret of choosing to have become a physician, and it is truly rewarding. So if anyone has questions about medical school or residency or becoming a doctor in general, the field of medicine, welcome to reach out to me.
Yeah, thank you so much for the work you do for our community. You're clearly like really passionate about it. So yeah, we're really happy to have you on.
Thank you so much. Thank you, Kevin and Zeal.
Yeah, thank you.
To be 3 of us, or is it going to be more participants?
There's going to be 3 of us.
Okay, yeah, I can get started. Hi, my name is Anne, or you can call me Dr. Xing. I'm currently a second year internal medicine resident at UCSD internal medicine program. So yeah, I'm here